I would like to introduce Dr. Archuleta to you. She attended medical school at Creighton University in Omaha, Nebraska, and completed her family medicine residency through the University of Iowa's Sioux City training site. She practiced in Jamestown for 3 years before settling in Bismarck, Mandan. She practices family medicine through CHI St. Alexius Mandan Clinic and sees patients for the inpatient palliative medicine program. She's the medical director for CHI St. Alexius Palliative Care and for the CHI Health at Homes Hospice Program. She holds a certificate of added qualifications in both hospice and palliative medicine. So at this time, I'd like to have her speak. So thank you very much.
Thank you. This is a completely new format for me, and this is a talk that I haven't done before, so I'm just warning you right now, we're going to be doing a whole lot of winging it today, but hopefully we're all going to learn something and it's going to be very valuable and all of that jazz. So, and I can't advance my own slides because I haven't figured out Zoom that well. So next slide, please. Okay, so we're going to start with just a little bit of a background on looking for anxiety, where you might find it, just some of the background pathophysiology type stuff. They estimate about 1 in 4 cancer patients and roughly about half of CHF and COPD patients will have some type of anxiety symptom. That's not the same as a full anxiety disorder, which we'll get into in some of the next slides, but that's a pretty high number, and to me, it makes a lot of sense that the CHF and COPDers are going to have a higher prevalence because of that dyspnea. I think there's a very close link between anxiety and dyspnea. They just tend to feed off of each other. So it's really tough to address one without addressing the other. As far as the more pervasive generalized anxiety disorder, which again we'll define in the next slide, but that's also a lot more prevalent than it is in the general community, with 3% of patients with advanced cancer meeting diagnostic criteria, and then 10% of the COPD patients would meet criteria. Next. Okay, so where does anxiety come from? The most common that we would see is in the palliative and end-of-life arena is usually anxiety that's triggered by some other symptom, whether it's the pain, the dyspnea, nausea, even arrhythmias, some of the tachyarrhythmias, pulses up in the 120s. Of course, they're going to be feeling a little more anxious with that. And then the other thing that I think is very common for us would be the last part of this slide, the existential and psychosocial. There's that anticipatory grief. They know what's coming. They know that they are very ill, and they see the changes that are happening, and trying to deal with all of that is very, very distressing, can definitely trigger a lot of anxiety. Questions about what legacy they're leaving behind, the burden that they're placing on their family, what's going on financially, and then of course the existential and spiritual questions all would definitely trigger anxiety symptoms as well. And all of those can be addressed in a little bit different ways than what we would look at for the nausea that would be the anxiety that would be caused by more of the physical symptoms. In between those two, we have the adverse drug effects. Corticosteroids, especially in your COPDers, would be something to keep in mind. Have they been on a prednisone taper that maybe went a little more abruptly than what they can tolerate, and now we've got kind of an adrenal crisis. Oh, that actually goes under the next one of drug withdrawal. But the corticosteroids themselves, as we know, insomnia, jitteriness, palpitations, kind of revs them up a little bit. So that would be certainly a trigger. Stimulants, we don't see, some of our cancer patients may use a little bit of Ritalin or something like that for the cancer-related fatigue, but probably a little more likely to be seeing over-the-counter stimulants like the caffeine, the energy drinks, trying to keep their energy levels up. Some of our antidepressants, the SSRIs, are used to treat anxiety, but paradoxically, and again, we'll cover this a little bit more detail later, but paradoxically, they can sometimes make anxiety a little bit worse. And then, of course, nicotine, we know, kind of can rev up anxiety a little bit. Withdrawal, opiates and benzos, especially if you're looking at a patient who's just come out of the inpatient setting, even though they may have been off their benzos, for example, for a week or more, especially if it's a benzo with a long half-life, like a clonazepam, the withdrawal symptoms from that can last weeks. When you're looking at the effects on sleep, sometimes it can take months to get that completely out of the system. So if you've got a patient whose anxiety you're really struggling to control, you might look at, what meds were they on a month ago? ago? Is there a long-term opiate? You know, maybe they've been on hydro 3 times a day for 20 years and that got stopped their last hospital stay. Make sure we're kind of looking at those things. And of course, alcohol withdrawal. We might see this more in the inpatient setting, someone who's had more of an alcohol use history at home than we were aware of and goes through some of the withdrawal usually about 2 to 4 days after being admitted. Metabolic, adrenal, we already talked about the discontinuation of steroids that they've been on for a little more long-term. Even if they're not on long-term steroids, I also see if they've been on repeated bursts of steroids over time, like the COPDers, many times with each progressive burst, you may be at a little bit more risk of adrenal crisis, or at least some mild adrenal insufficiency as you're weaning. Serotonin, keep in mind how many different medications affect serotonin, like even the tramadol. There are certain antiemetics that are serotonergic. So the serotonin syndrome is getting to be a lot more prevalent than what we'd seen in the past, and that can certainly rev up anxiety. Next slide. Okay, so is it anxiety as a symptom? Is it anxiety as a disorder? How do you know? Different subtypes of anxiety, the most common or the most prevalent would be the generalized anxiety disorder. The definition, I mean, all of these definitions are kind of intuitive, but you know, we need to go through them. So with generalized anxiety, it's a pervasive or excessive worry that lasts over 6 months. So this is not someone who is just having some anxiety because of a new diagnosis or that anticipatory grief, anticipatory anxiety. This is a more pervasive thing that probably was with them pre-morbid. The physical signs and symptoms that you would see would be the 6 that are listed there. They need at least 3 to meet the diagnostic criteria: the restlessness, easy fatigue, problems with concentration, irritability, muscle tension, and sleep disturbance. Or if you're looking at that list, to me, that's just, you know, a typical Monday morning, but, you know, I guess everybody's different. So 3 out of those 6 criteria for a duration of over 6 months, particularly if it's not triggered by a psychosocial stressor, that would be the generalized anxiety disorder. That gets to be significant because if you're treating anxiety that's less pervasive, that's just a symptom, versus the more pre-morbid generalized anxiety, you're going to take a little different approach with the pharmacology. Phobias, of course, marked persistent fear of a specific situation or object. In healthcare, of course, the needle phobias, those who have claustrophobia or PTSD may struggle with the oxygen masks, the CPAP masks. Definitely important to be asking about specific phobias, especially if you find that there are certain treatments. The patient will not come out and tell you that I get anxious when I have my CPAP mask on because I was attacked 6 years ago. They generally are it's a little tougher to tease that out. So just kind of be aware of where you see your specific triggers. So as you can see, the phobia sometimes can overlap with the panic disorder and even with the PTSD. The panic disorders are recurrent panic attacks, and the phobias have a specific trigger. The panic attacks don't have to have a trigger. I've had many anxiety patients in my family med practice who will wake up in the middle of the night with a panic attack, or they're just sitting on the couch and they feel perfectly chill and life is good, and all of a sudden they're in the middle of a panic attack. And they say, "Doc, that can't possibly be anxiety or panic because I was feeling calm." The human body really doesn't care about emotion when we're talking about anxiety. Anxiety is not just the emotion of feeling worried. It's the adrenaline response. It's the fight or flight that gets kicked in. That's what triggers the panic attack. And so it's very common to see the panic disorders and not necessarily know that there's an associated anxiety. Adjustment disorder, probably a little more common in most of our palliative and end-of-life patients, especially if, well, this is kind of intuitive, but if they didn't have the pervasive generalized anxiety prior to the diagnosis, then you're probably looking more at an adjustment disorder, which is generally within 3 months, although some definitions I think would say even up to 6 months of the stressor. And you will see a lot of the same triggers and the same signs and symptoms as you'll see with generalized anxiety, but and the marked distress and functional impairment are the GAD, or I'm sorry, the DSM definitions of any psychiatric or psychological disorder, you have to have that marked distress and impairment in function. But again, the adjustment disorder is more associated with a specific event or stimulus, whereas the generalized anxiety just is. And then the PTSD, the criteria would be this hyper arousability. These are not people that you want to sneak up behind and say hello to, because they will like jump out of their skin. Emotionally numb, we're not talking physical numbness, we're talking about emotionally numb. They just feel flat, but they feel just incredibly revved up all the time. Flashbacks, nightmares, intrusive thoughts, and then avoiding the stimuli that triggers a lot of the flashbacks. Next. Okay, so evaluating a patient with anxiety. Obviously, your history and physical are main starting point, as they are for most psychological diagnoses. Looking for the premorbid history of any mental illness. Have they seen a psychologist in the past? Many patients who have an anxiety-based disorder may not know or realize that they have that disorder. So they'll say, no, I don't have any problems with anxiety or depression. And then you ask, well, have you ever seen anyone in the mental health department? Have you ever been on any medication for your mood? And oh yeah, you know, I guess I've been seeing a psychiatrist for 6 years, but I don't have any anxiety. So it kind of depends on how you ask the question. And then also we're looking for, are there specific triggers to help us sort out the phobias, the panics, and the PTSDs versus the generalized anxiety. Physical symptoms that we'll see can overlap a lot with some of the symptoms that we're seeing from the underlying illness. The diaphoresis, dyspnea, the tight muscles, the shakiness, that hypervigilance, some of that can be very similar to what we would see with our end-stage diseases and uncontrolled other symptoms. So there is a lot of overlap there. Make sure that we're keeping in the back of our minds the differential diagnosis, keep the agitated delirium. Delirium is defined as waxing and waning in level of consciousness. So these are patients that are completely appropriate, answering questions 1 minute, and then you come back in an hour and they are completely out to lunch and they cannot tell you where they are or what they are. A dementia is more pervasive. A dementia generally doesn't lift. They always have that altered level of consciousness, whereas a delirium will wax and wane. So delirium with agitation a lot of times will look like an anxious patient, but when you question a little bit more, they're disoriented, they're cloudy, they're foggy, they're delirious rather than just anxious. And then the akathisia is one that I admit I have a very hard time keeping that one in the differential. I think I've only seen it maybe 2 or 3 times in the last decade, but it is definitely one that you don't want to miss. That's the motor restlessness, the tremoring, the jerking, some people describe it almost like a restless leg where they just can't hold still. And that's usually a result of some of our antipsychotics, especially the dopaminergic ones, the Haldols, the Zyprexas, some of those, and then some of our antiemetics, like the Zofran and some of those that can affect dopamine as well. There are a number of screening tools out there. Our institution likes the GAD-7. It's 7 questions. It's easy to score. It's pretty easy for patients to fill out. There's a ton of them out there. I didn't go into a whole lot of specifics. I think it's a good idea to have one in practice and pick one that is your favorite. It should be something that the patient can easily understand, that can be done and scored in under 10 minutes so that clinically fits in with your patient flow, but there really is no consensus on this is the gold standard for diagnosing an anxiety disorder. Next. Okay, so what are we going to do with them? Always start with the non-pharmacologic. I think as providers, as physicians, APCs, we have this gut reaction that a patient comes in with a symptom and I need to give them a prescription, and I do this all the time. Anxiety is one where if we can resolve the stimulus of the anxiety, we're going to do a lot better in the long run than if we're just medicating over it. Don't underestimate the power of some of the non-pharmacologic treatments. There are some excellent mindfulness apps out there where they'll have anywhere from 30 seconds to 3 minutes of guided imagery or deep breathing or something like that to kind of help a patient get out of their head and get back into their body. That's how I describe it to my patients. As anxiety, you just get so wrapped up in your own thoughts. You need something to reconnect you with the physical world around you. So any type of sensory stimulation like aromatherapy, music, looking at pictures or artwork or something like that, looking at pictures of family, reading a book, anything that gets them back in touch with the physical environment around them tends to get them out of their own brain a little bit. Distraction can be something as simple as, tell me about your childhood. I can remember a guy, he was a 35-year-old, this is a horrible case, 35-year-old heroin addict that was dying of testicular cancer and was sitting up on the floor just rocking back and forth. His anxiety was partially treated withdrawal, plus uncontrolled pain, plus just the fact that he was 35 and dying. There was a lot of existential stuff. But I can just picture him sitting, just rocking at the edge of the bed, just angry as heck. Get me my meds. Why aren't you pushing my medications? And I asked him, tell me about what you used to do. And he stopped. It took him a minute before he heard me because, of course, he was so revved up. But after a couple of questions, he started telling me about what life was like before he got ill and what are you most proud of? And he was telling me about the things that he had built with his hands, and just watching the change in his demeanor was so cool. And by the time we had kind of talked for a few minutes, the nurses had a chance to push their meds and kind of help him with the pharmacology that he obviously needed. But don't underestimate just the importance of just being there, holding a hand, touching a shoulder, listening. I may not be able to fix this for you, but let's see if we can make it suck a little bit less. And just that empathy really does help to disarm anxiety. When it comes to pharmacotherapy, depends on the type of anxiety we're treating. For the SSRIs and the SNRIs, those are more of the pervasive daily disorders or daily anxieties, like the generalized anxiety disorders. The way I describe it is it's a difference between preventing a fire versus putting out a fire. Your benzodiazepines are going to be more for extinguishing a fire, whereas the SSRIs, the SNRIs, the mirtazapines, those are designed more to try to prevent anxiety in the first place. The SSRIs would be Prozac, Paxil, Zoloft. I'm only using I'm supposed to not use brand names. Sertraline and escitalopram and citalopram and fluoxetine. We're pretty familiar with the SSRIs. They've been the workhorse for treating anxiety for many, many years. They have a good safety profile. Escitalopram especially tends to be a little bit more activating. So I like escitalopram because it's got a lot quicker time to steady state. The fluoxetines and sertralines are 4 to 6 weeks. Escitalopram is 1 to 2 weeks. So it's great when you've only got a patient with a prognosis of 2 months. But because it's a little bit faster, sometimes it revs them up that first couple of days. So sometimes we will use a benzodiazepine for that first couple of days until they kind of learn to their body adjusts to the escitalopram. The SNRIs are really nice because they usually have a secondary effect of helping with, especially with neuropathic pain. That would be the duloxetine, venlafaxine, desvenlafaxine. There we go. Those are the big three in that category. A lot more side effects. From anecdotally, at least what I've seen is there's more of the somnolence and the grogginess with some of those, although it's really tough to predict. Some patients will do terrible with SSRIs and they do better with SNRIs. So my general treatments, especially in my primary care anxiety, I'll usually try about 2 different SSRIs first, and then I'll jump over to the norepinephrine, the SNRI. The difference in mechanism, again, selective serotonin reuptake inhibitors only affect the serotonin in the brain. The SNRIs are serotonin and norepinephrine reuptake inhibitors. The first in the class was Effexor or venlafaxine, and that one at lower doses is more serotonergic, and at higher doses is more noradrenergic. The norepi seems to be more affecting the physical symptoms of anxiety. So if patients are doing okay on the 75, but they've still got a lot of the insomnia and the agitation and the panic, we'll maybe push them up to 150 or even 225 to try to get a little bit more of the noradrenergic effects. Mirtazapine is kind of its own category. It's not a reuptake inhibitor, it's more of a direct agonist. Mirtazapine is one of my favorites because of its side effects. It makes you tired and it makes you hungry, which makes it a very useful palliative drug. They do say that the somnolence is less at the higher doses. The only thing I know about psych drugs is that they're unpredictable, and what you think they're going to do is not what they do, so whatever. But so I start people at 7.5 usually of the mirtazapine, depending on how tolerant they are of medications. I warn them that they may have a little bit of hangover the first couple of nights. Bear with it, it usually improves improves within a couple of days. It definitely does help to improve the appetite. People will sleep better at night, and then it does have an anti-anxiety effect as well. With the benzos, there's like 12 of them in the class. Pick 2 or 3. The short-acting ones would be the lorazepam and the alprazolam. Clonazepam has a much longer half-life. That I use when I can't control anxiety any other way, and I've really got to get somebody on a more consistent schedule. I'll use the clonazepam scheduled. Generally, try not to use more than 1 benzo at a time because it just increases your risk of side effects and accidental overdose and all that kind of stuff. Again, the benzos are GABA agonists. They attach to the same part of the brain that alcohol does. So that's why it gives you that calming, that kind of dampening, kind of mellows you out a little bit. That's also where they can get to be habit forming. And that's the exact analogy that I use with my patients to help them understand that this is a useful medication, but we do have to be cautious with it. And then I generally do not use these for my primary care and even for some of my healthier palliative patients, but when necessary, the antipsychotics can be extremely helpful, especially for the more agitated, more physical symptoms of the anxiety that you can't get at any other way. Haloperidol, of course, is the gold standard for end of life, terminal restlessness, and also some of the more severe anxiety. The olanzapine we tend to use a lot more in some of our cancer patients, especially now, and we are starting to, as we get more familiar with the drug, using it a little earlier in the diagnosis process, because that one also, we use it at bedtime, helps with sleep, and then it also definitely helps control the nausea as well. So it's a nice secondary benefit. Okay, and we can go next slide, which I think that's the last of the slides. Yep, that's it. Oh, that's next month. You'll have to come back for creative symptom management. So I think now you'll have to guide me, Julie and Nancy. We move to the case report.
Yep, we'll do the case next. So will you pull it up then, Julie?
I'm sorry, say that again, Nancy.
Can you pull the case study up?
Sure.
Okay, so we're going to do a brief one. This is a little bit, we're just going to use the initials MR. He's a 58-year-old gentleman. He had a long history of smoking, known COPD, developed a patch on his tongue. He didn't seek any attention. He continued to smoke. He chewed. He has been married 35 years, 2 children in the early 20s. He does have 1 grandchild, and he worked as a farmer. Next slide, please. So about 6 months ago then was the first time that we got involved with him. He did have something that he felt was catching in his throat, more difficulty with swallowing and moving, had trouble speaking and such, and more and more numbness of the tongue. So they decided to do a full workup on him. And so it was found that he did have cancer in his mouth, with including the tongue and the floor of his mouth. So he had a surgical resection done and had some of the bone and soft tissue removed as well. He did have feeding tubes for a while, but then was able to swallow after a period of time, but it continued to progress. And even with this, we had necrosis going on. He had more loss of the tongue, could not speak anymore. He was losing teeth all the time. His face was definitely more disfigured at this point in time, and more pain was going along with that. He had more cancer, ulcers going on. He had definitely malodorous breath all the time, some halitosis going on. So it was uncomfortable for him to be around people as well too. Next slide, please. So we right away saw that he had this acute mouth pain going on. He was developing more and more shortness of breath with that. And along that, of course, was the anxiety, both for where he was currently and thinking ahead, you know, and family concerns that were going along as well too. Next slide. So we started with, we had started with morphine. We went to methadone. We used the immediate release MSIR, and then we eventually went to a PCA. That seemed to be the best way for managing it for that. He did have a lot of nausea and vomiting. We used the Haldol, which we're hoping a little bit for the anxiety, but it was used more for the nausea and vomiting, and did help with that. For the dyspnea, not only did we have the opioids, but we used oxygen, we used nasal cannula oxygen, he used a bedside fan. He liked the handheld fan, that was his favorite. But now we are left with what's going to be the best success for him for anxiety, and that's where we're going to end. So just up for discussion. I forgot to add some of the symptoms on these slides too. He did develop definitely restlessness. He had terrible difficulty with fatigue, could not sleep, was up all the time, very irritable. He had a lot of panic attacks. That was a good description when you're talking about that, Dr. Laura, because we did see that with him as well. So that's where we are, or that's where we ended, and just wanted to find out what you were recommending or what others are recommending based on what you've presented for helping with the anxiety, knowing he has family, etc. Spirituality, I forgot to add that too. We did have our chaplains coming in. He was very upset the fact that he brought this on himself from smoking and all of that, and that he was letting his family down because he knew he was nearing the end of life, that his time was very limited, and he had real hard time with that component as well.
Okay. So am I supposed to just jump in, or are we looking for general conversation?
Go ahead and start. It would be great to hear kind of what you would think if you came across this gentleman.
Well, my first thought is you had to give me somebody on methadone. there's more drug interactions.
No, but we got him off of it and we went to PCA. So he's at a morphine PCA.
Oh, sure.
That's how we started.
Oh, there we go. Okay.
Yeah. We went back and forth. We started with morphine, long acting, went to methadone. So it's been over a period of time, the 6-month period of time. So now we're on a PCA.
Oh, sure.
Morphine PCA. So we're not on methadone now at this point.
Okay.
Of course.
And with the methadone, I mean, yes, there are more interactions, but again, you've got to kind of take it in the context of the overall patient. If this is someone with a limited prognosis and we understand that the goals of treatment are palliative, not curative, I will kind of push some of those drug interactions depending on what it is, especially like the QT prolongation. The rule of thumb that one of the pharmacists taught us was try to avoid, it's a cumulative effect. So try to avoid more than one. If you try to keep it at maybe 2 QT prolongers, not 4, and try to keep your doses moderate. And really, that's about the best you can do with some of them. In this guy, I think, considering the symptom constellation, I think I'd be inclined to start him with mirtazapine. It'll get the sleep under control a little bit faster, which by itself, if they're sleeping better, you're going to get better control of the anxiety. And that one, too, doesn't seem to take the 4 to 6 weeks to kick in. It seems to be a little bit faster, too. So I'd probably start him on mirtazapine 7.5 at bedtime. While as far as the non-pharmacologic stuff, I'd definitely like to have him working with a chaplain or social worker through some of the grief and anticipatory grief and the guilt issues. If your area happens to have an end-of-life doula, which we're fortunate enough, I had never even heard of this till about a year ago. They're very similar to the doulas for labor and delivery, where they just walk you through that transition and they help with life reviews and legacy and those kinds of things. I'd really focus on that with him. It sounds like he's got a lot of existential stuff that he needs to kind of work through as well.
What about introducing benzos at all? That was one thing that we went round and round with. He's on the Haldol already, but we didn't know if a benzo would be good, either short acting or long acting. That was another one we went around with.
Do you think the Haldol helped much?
No, it wasn't. Not for the anxiety. It did. We seemed to help with the nausea and vomiting, and then he didn't even have a feeding tube anymore, and whatever he could take, which wasn't much anymore. So we know his life was very limited. That he was probably moving from into almost like a hospice scenario, but not quite there yet. So,
I think I would consider a short-acting benzo. I would probably push the dose on the Haldol first. The 0.5 is our starter dose, and to get the anti-anxiety effect, sometimes you have to get closer to 1 to 2 milligrams, depending on side effects. But you'll know that pretty quickly. So I would titrate up on the Haldol, and if no effect by, if you get to 2 milligrams and you're still not seeing any improvement on the anxiety, then I'd probably say, yeah, let's go ahead and add in probably a lorazepam, like start at a 0.5 and see how he does with that.
And when you were talking about the mirtazapine, how soon do you see effects? Are you talking like days instead of the weeks then with that you've seen?
And I still don't know how much of this is placebo, but when I've used it in the hospital within 3-4 days, I think a lot of that has to do with the fact that they are sleeping a little bit better, and that, kind of helps improve the mood a little bit. I'd say efficacy, usually roughly about 2 weeks.
Okay. This, like I said, this was a very difficult case
Yeah.
because of all the things going on and the psychosocial component of it, and breathing and all of it, because that dyspnea, that in itself can add to the anxiety, and then the family stress that was going on with it too. So
Yeah. And especially with the dyspnea, opioids, yes, are gold standard for dyspnea, but when you have dyspnea and anxiety, a lot of times it takes a benzo to really get both of them under control.
okay, that's good to know. Okay, so we're going to open it up for chat. Other questions or anything for both regarding the case, as well as if you do have any other cases or something you would like to bring up for everybody else. You can either add it to chat or feel free to unmute yourself and bring a question to Dr. Laura. I'm sure everybody's had other cases too with the anxiety, different degrees of it. So what has worked, what hasn't worked? I didn't know everybody had no issues with anxiety. That's amazing. Dr. Laura, can you just present like a case or something that comes to mind for you that
Nancy?
oh yes.
Sorry, this is Julie. We actually do have something in the
Oh,
chat.
sorry, my apologies. I just saw it come up. We have, in regards to dementia, what are recommendations for preventive measures for anxiety?
Oh, well, for dementia, you definitely want to take the fire prevention versus the fire extinguishing approach. I would lean more towards an SSRI or maybe an SNRI, depending on the case. Benzos, the standard story is that we want to avoid them if at all possible, and I would definitely agree with that, because with a benzo, you're clouding the sensorium a little bit. So you've got somebody who's already disoriented, and we're adding a medication that's going to make them feel a little more groggy, and that's where you get that paradoxical effect. You've basically got someone who's already confused, and now you're making them drunk and confused. So you definitely can see that paradoxical anxiety. So if I do have to use a benzo, I'm going to start like 0.25 of lorazepam instead of 0.5, or 0.125 of Xanax. Generally, we go with lorazepam instead of Xanax because the Xanax has a very quick onset and a shorter half-life. So the lorazepam is still going to be a fairly rapid onset, but it doesn't hit you quite as hard and disappear quite as abruptly as the alprazolam does, which lowers its addiction potential and also makes it a little bit better tolerated, especially in the elderly. So a geriatric depression, a lot of these, again, have problems with sleep. They get their days and nights mixed up. They're not eating real well. So if it's somebody that's still at a point where they're taking an oral and doing it fairly early in the dementia process, I'd be looking at something like mirtazapine also.
Now, I was going to ask about that, or Haldol. Is Haldol helpful for people with dementia?
Haldol is a big no-no, especially if you've got a patient in a nursing home. You will get angry phone calls from the pharmacist. And the black box warning on haloperidol, and we do go over this even with our palliative and end-of-life patients, the black box warning says that a patient on an atypical antipsychotic or any antipsychotic, so that would be your Haldols as well as the newer generation like the olanzapine and risperidone and Seroquel, quetiapine, any of those have a black box warning that there is a higher risk of sudden death when used in patients with dementia. Yes, we do use them, but we want to exhaust all options first, and we want to make sure that the family understands that this medication could be very useful for symptom management, but it doesn't come without risk.
Another question has come up now. Are there any side effects with these anxiety meds and medical marijuana?
With mixing the two? Probably, okay. Mixing the two, I would look at risk of oversedation, just because the marijuana is going to be kind of more mellowing, and your SSRIs, and more so your benzos can be as well, so it would be kind of an additive effect. I know a lot of patients are using CBD, and CBD has some literature to support it for anxiety. What I've seen anecdotally with my patients is that they're not seeing, my little old ladies who are using it topically for joint pain are loving it. They're saying that it definitely does help. That especially my younger patients who are using it more for anxiety are saying they're not seeing as good of an effect. If I have a patient who's on a lot of medications, I do tell them to avoid the ingestible CBD, because CBD is a cytochrome P450. I can't remember if it's an activator or an inhibitor. So it does interact with certain meds like diflucan and like some of the anti-seizure meds and stuff. So do not believe what they tell you, that it's natural and it has no drug interactions. We all know that it's never that simple. I would be willing to combine the other pharmacology for anxiety in a patient who is using medical marijuana, but I would start at lower doses and I would titrate more slowly and warn them about possible sedative effects.
So what would be your if they are on medical marijuana and you're going to be introducing something as an anxiolytic, what would you be thinking?
I'd probably go more SSRI, SNRI, mirtazapine, somewhere along those lines, like a sertraline 25 milligrams, or if it's somebody that's really sensitive to meds, I'll even start them at 12 and a half. The mirtazapine 7.5 is probably about the lowest you can get with that one. And SNRI, I like with duloxetine, I like that it does, usually it's 30 milligrams for the first week and then up to 60 if you're dealing with a general adult. For the geriatrics and the more vulnerable population, I like to start it at 20. They do make a 20 milligram capsule with that one. And there too, if you've got a lot of neuropathic pain or something like that, that you're using your marijuana for too, you know, that's kind of a nice secondary benefit. Effexor, I'd start at the 37 and a half. And generally for a healthier population, we start at 37.5 for anywhere from 3 days to a week. In this population, I'd say 37 and a half, and then leave it at that for at least 1 to 2 weeks before reassessing.
And again, if you're on a short course, like if you're nearing hospice time and somebody's on medical marijuana, anything for anxiety that you'd recommend?
Then I would be more inclined to do, well, then you'd have to go either antipsychotic or benzo. I probably would go benzo first. But again, it'd be the 0.25 of lorazepam and titrate accordingly. That'd probably be my starting.
Please feel free to write questions in the chat box or open up your mic. Come off mute. And has everybody, just a reminder, please, everybody include your name and affiliation in the chat box so that we do have an attendance sheet for today, please. We see that there are some people that haven't signed in yet. So Dr. Laura, I'll put, oh, we have another one. We have a child with Batten's disease and struggles with tremors. She's currently on taking lorazepam for the restlessness, mixed results. Comment, Dr. Laura?
Yeah, I don't know much about Batten's disease. Huh. Mixed results as in partial response, or are you seeing a lot of bad side effects too?
You want to come
with tremor?
Yeah, Emily, do you want to come on and talk to us about it? That would be helpful. You just have to click your mute button over on the left-hand side of the screen.
There we go.
Can you hear me okay? Sorry.
That's great. Thanks, Emily.
Yeah, mixed results where we're having some success when she's taking lorazepam, but other times not as much. It just, I don't know. It seems like the mom thinks it's working, and then other times she's still having the tremors.
Is she agitated? Does she look anxious, uncomfortable, or is it just more of an isolated tremor?
It depends. I was there with our chaplain, and she was kind of scared of us at first, and so it kind of began the tremors. But at home, even when she's around her family who she's comfortable with, she'll experience them. And that's a symptom. It's a new symptom that she's experienced probably within the last month. And from what we understand, the Batten's disease is that it's kind of a combination of Parkinson's, Alzheimer's, and just, it's just kind of a horrific
yeah, I'm Googling it. I tell my patients, don't ever Google. That's the 11th commandment, thou shalt not Google. But yeah, I don't know. As I'm looking at this, wow, this looks like a horrible disorder.
Yeah.
Okay. Yeah, seizures,
it's really
dementia.
sad. Her and her sister both have it.
Wow. I might be. Is she on any other dopaminergic meds for tremor, like the Cinemet or anything like that?
I'm kind of pulling up her stuff right now. Not that I know of them, but I'm a social worker, so I mean, I don't see anything. So
but that's even better. That's even better.
Good. So if I say something wrong, you won't notice.
No, I mean, she got a seizure, so I guess that's what they're using maybe the Keppra for. Other than that, I don't really see anything.
Gotcha. Okay.
Diazepam, I guess they have for anxiety and seizures.
Okay. So diazepam is in the same category as the lorazepam. So my personal preference would be to pick one or the other. If you're looking to treat anxiety, maybe, and if you think the tremor is anxiety related, maybe you titrate the dose a little bit. If you're having, sometimes you think it works and sometimes it has no effect, then I'd be inclined to increase the dose. And usually with this one, it'd be about, you'd probably be, if you're starting at 2.5, I'd go up to a 5. If you're starting at a 5, I'd go up to a 10. So essentially you'd be going up in 50% increments. So increasing the dose. But if you're thinking sometimes it seems to work, sometimes it makes things worse, then in that point, I'd probably be looking at switching drugs. The Valium's got kind of a mid-range half-life anyway. One of my thoughts was, geez, I hate it when my brain stops functioning. Clonazepam, because it's got that longer half-life, and you could almost have her on it. The neurologist will use clonazepam for tremor, so you could almost have her on it scheduled throughout the day for both the tremor and the anxiety. That might be an option, but then your Valium, the diazepam, also has kind of that middle to long range half-life. So just to avoid polypharmacy, especially in a kid, I'd be more inclined to say, let's push the diazepam dose up a little bit and schedule it. This is a patient where I would look at doing possibly an antipsychotic like a Haldol. You do get more risk of the Haldol can be antagonistic to what a Cinemet would do. Cinemet calms tremor. Haldol can sometimes make tremor worse. So you would have to use with caution, but as far as correcting the underlying, because if this is progressing where she's getting the personality changes and the dementia that you can sometimes see with this, according to Dr. Google, then a trial of haloperidol would probably be reasonable. I'd go with a low dose, like maybe even a 0.25, depending on how old and how big this kid is. And I'd want somebody kind of with her for a couple hours afterwards, just to watch for any paradoxical effects and stuff.
Okay. And I know this is a chat about anxiety, but I just randomly, the other symptom that she's experiencing that we don't really know is just excessive drooling. Don't know if you have any recommendations. I think that they tried a little bit of, I don't know, some lesson to see if that might help, but I don't know that it's helped anything. So.
And you're gonna have to be careful too, because Levsin and the anticholinergics can worsen confusion, which might make her dementia a little bit worse as well. Glycopyrrolate is also an anticholinergic, but it tends to have less CNS effect. And I think there's a little bit broader dosing range with that. So glycopyrrolate would be one to look at. Depends on your pharmacy. I've heard it's outrageously expensive, and I've heard, no, it's not, it's pretty cheap. So you'd have to kind of look at that one. Yeah, I think that would be the safest anticholinergic I can think of. If anybody else has any ideas, please jump in, because I certainly don't know everything.
Thank you. Appreciate it.
Sure.
That was a very great discussion, because we do get those. That's the other thing in North Dakota, we get those outliers too. So it's not all the common kind of things we see all the time. So we really appreciate discussion and dialogue about that as well. Do we have any other cases that someone can bring up? We have a few minutes left. Dr. Laura, do you have any other cases that were kind of, either generalization that a lot of people may see, or kind of a wow factor at all with anxiety?
One specific one isn't really coming to mind, but I think just that interplay between anxiety and pain is definitely something to watch for. One caveat is, if you hear a patient who is rating their pain scale at greater than 10 on the, oh, my pain level is a 15, that is an anxiety patient until proven otherwise. Or that is a patient who has some type of existential pain that isn't related to physical pain. So that should always be a trigger for us to be digging deeper than just controlling the pain. I think the other thing that I've found is that when we control the anxiety, the need for PRN pain medications gets a lot better, because the fear of pain sometimes is as bad as the pain itself. So you see some of that pseudo-addictive behavior where they're hoarding their meds, they're asking for early refills, they're wanting to titrate the dose, and it may not necessarily be that they're med seeking, it may be anxiety related to the symptom of pain. So just to kind of keep it, make it on the top of your differential diagnosis. I mean, in my family med practice, my nurse practitioner started with me about 3 years ago, and the first thing she said is, I had no idea how prevalent anxiety is. I mean, it's just everywhere, and I think it's a product of the American lifestyle. So it definitely needs to be something that is on our radar and being addressed right up there with pain, nausea, and all the other physical symptoms.
And along the same lines, I find some of the patients and clients I've worked with are the ones with dyspnea, and that anxiety that adds to the dyspnea, and it goes back and forth constantly with that. And so many of providers are very reluctant to treat the dyspnea with any kind of low dose opioid, and so they're maxing out all the other kinds of anxiolytics. That's been a real hard one that I have seen too.
Yep. As far as the combo between anxiolytics and opiates suppressing respiratory drive, I have to go back and find the study because it was so helpful to me. They found that the highest risk for unintentional overdose and ED visits for side effects is within about the first 72 hours after a dose change. Once patients are on steady state with an opiate and a benzo, the risk goes way down. So especially in our patients with limited prognosis where symptom management is a top priority, you can use these meds in combination. In fact, we use the synergism a lot in hospice. But again, we have to start with lower doses. And if it's an ambulatory patient, maybe you're having your nurse do a phone follow-up in 24 hours to see how are you doing? How did you tolerate that dose? Do we need to go down on something? And again, patient education, making sure that they know that these two meds together could kick your butt for the first couple of days. So just don't plan on driving, make sure you got somebody with you and some of those kinds of things. I tell my patients knowledge is power when it comes to anxiety because anxiety is all about the unknown. So within reason, the more information you can give them, we don't want to overwhelm them, but we want to empower them with as much ability to make their own choices, ability to be participating in their treatment plans. And, these two meds are both good options. Here's the pros of one, here's the pros of the other, and have them participate in that decision making. All of those little things that we do to increase patient rapport are also going to diffuse a lot of their anxiety as well.
Excellent advice. Really appreciate that. There's another question. Does anyone have a good scale for end-of-life anxiety? Sometimes those GAD questions or the PHQ-4 seem hard to ask or ridiculous to ask patients because of their stage in life.
Good point. I guess I personally have never looked for any specific palliative anxiety scales. If anybody's got a CAPC membership, I would bet that they've got some that are more specific. That's also where we look at a lot of our nonverbal cues and get to know what they were like pre-morbid, if they had an underlying anxiety history in the past, and now we've got uncontrolled pain and uncontrolled nausea and uncontrolled this, that, and the other thing, there's going to be some anxiety involved.